Subcommittee on Oversight and Government Reform on Healthcare Benefits Administrative Rules will come to order. Without objection, the chair is authorized to declare recess at any time. Welcome, Mr. Cartwright, and welcome our witnesses. We'll get to you in just a moment. We'll do opening statement. You know how this works. You've done this many times, opening statements, and then we'll get your testimony. Then we'll get right to our witnesses. Everything, just about everything stated about Obamacare when it was passed has turned out to be false. Like your doctor, you can keep your doctor. False. Like your plan, you can keep your plan. That turned out to be false. Premiums are going to go down, that we were told. That turned out to be false. Premiums are going to go down an average of $2,500. Of course, that turned out to be false. The website will work, we were told. That turned out to be false. The website's secure. That was false, too, at the time. Deductibles will decrease. We found out that wasn't accurate either. And, of course, we were told 21 million people would get insurance under the exchange. Now that's been revised down to almost half, 11 million Americans. And of course, we were told the co-ops were going to work. Just yesterday, Illinois' co-op folded. That's the fourth one since May. That's 16 now out of 23. That's after the administration spent $2.4 billion setting up nearly 24 co-ops. Over $1.6 billion in federal loans have gone to the failed co-ops. Money that probably will never be recovered. More closures are expected. My guess is every single one of these, every single one, all 23 are ultimately going to fail. And that's why we're having this hearing today. To just underscore the simple fact that it's not only just co-ops, it's not only some of the things that it's just, this law has been a complete failure. And the American people know it. Business owners know it. I think insurance companies know it. And we're looking forward to hearing from our witnesses today on the co-op issue and other issues related to Obamacare, or some call it the Affordable Care Act. So I want to thank our witnesses for being here, and with that, I would now recognize the ranking member, Mr. Cartwright, for an opening statement if he has one.
Thank you, Mr. Chairman, and I'd like to thank our witnesses for taking the time to be with us today. I hope the committee uses this hearing as an opportunity to have a meaningful, productive discussion about the ACA, what aspects of the law are working, areas still in need of improvement. But I've been on this committee long enough and this subcommittee long enough to know that this hearing was called to give my colleagues in the majority an occasion again to attack the law. In fact, just the one-sided title of today's hearing says it all, from premium increases to failing co-ops. A fair approach might be titled, from improved access to health care to historically low uninsured rates, or from reducing medical debt to slowing national health expenditures. But, of course, my Republican colleagues don't want to highlight the ACA's successes, only its flaws. That's the kind of partisan political hearing they believe serves their interests in an election year, but another partisan hearing doesn't serve the public interest, because there are some of the accomplishments of the ACA that the Republicans' partisanship ignores. Because of the ACA, 20 million people who used to be without insurance now have access to quality, affordable health care coverage. And what that means at home on Main Street is that your hospitals, your local hospitals, are much less likely to fold because they're not doling out as much uninsured care as they used to have to do. That's true in my district. We had 2 hospitals that failed after 2010 and before the implementation of the ACA. But here's another accomplishment. The uninsured rate in this country is at an historic low. That means there are fewer people in this country than ever before that have to worry about what happens if they get sick, they can't afford to go to the doctor, or can't afford to pay for their medications out of pocket. And here are some more accomplishments. Because of the ACA, people with pre-existing medical conditions can no longer be denied access to coverage because of their health. Hospitals in states that expanded Medicaid have seen their rates of uncompensated care decline, as I just mentioned. Those states have also seen a decline of medical debt. So many of the people that declared bankruptcy in this country had to do so because medical debt put them underwater. But even with all these accomplishments of the ACA, my Republican friends have chosen to hold more than 60 votes attempting to repeal or undermine this law. Now, we all know there are aspects of the ACA that still need a lot of work. For example, co-ops have faced daunting challenges, just as any startup businesses would. We have to remember the reason that co-ops were created, to inject much-needed competition into the insurance market so that rates can stay low for consumers. Instead of taking steps to help support the co-ops, however, the Republican-led House has voted multiple times to slash that program's funding. And there are certainly other aspects of the law that could be improved. I'm looking forward to hearing from our witnesses about how we can make the ACA better, how we can make it stronger, and work for all Americans. But I'd like to close by focusing on why we passed this law in the first place. In June 2015, Brent Brown of Wisconsin wrote the President a letter thanking him for enacting health reform. Mr. Brown, who has, quote, voted Republican for the entirety of his life, unquote, but who also had a pre-existing medical condition that made it impossible for him to get health insurance before the ACA, he wrote, quote, I would not be alive without access to care I received due to your law, unquote. Mr. Brown's letter is a reminder to all that the ACA is about helping real people live better, healthier lives, and it is working, unlike the harmful proposals recently put forward under the Speaker's Better Way plan, which would roll back health care protections for women, raise medical costs for seniors, and cut long-term Medicaid funding to the detriment of patients and medical providers. After 6 years, Republicans still have not proposed a viable legislative alternative to the Affordable Care Act. I would urge my colleagues to keep this perspective in mind during today's hearing. And Mr. Chairman, I yield back.
I thank the gentleman. We'll hold the record open for 5 legislative days for any members who would like to submit a written statement. And we'll now recognize our witnesses. I'm pleased to welcome Mr. Kevin Kunahan, Deputy Administrator and Director of the Center for Consumer Information and Insurance Oversight at the Center for Medicare and Medicaid Services, the U.S. Department of Health and Human Services, and Ms. Linda Blumberg, Ph.D., Senior Fellow at the Urban Institute. Welcome again to both of you. And pursuant to committee rules, all witnesses will be sworn in before they testify. Please raise your right hand. If you would stand and raise your right hand, excuse me. Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God? Let the record show that both witnesses answered in the affirmative, and we will now start with, we'll just go right across, Mr. Kunahan and Ms. Blumberg.
Great. Good afternoon, Chairman Jordan, Ranking Member Cartwright, and members of the subcommittee. Thank you for the opportunity to provide an update on the Affordable Care Act. I joined CMS nearly 2 years ago after over 30 years serving various roles in the health insurance industry. At CMS, my focus is on the day-to-day operation and management of the marketplace and other programs that help consumers gain access to affordable, high-quality health care coverage. Thanks to the Affordable Care Act, millions of Americans who were previously uninsured now have access to affordable, high-quality health care. An estimated 20 million more people now have coverage because of the law, and at 9.1%, the uninsured rate in America is the lowest it has been on record. Pre-existing conditions no longer preclude individuals from gaining health insurance, and lifetime and annual dollar limits are now a thing of the past. Tens of millions of Americans have new access to preventive services with no cost sharing, and consumers now have the comfort of knowing that if their employment changes or if they lose coverage for any reason, they can purchase affordable coverage through the marketplace. The Affordable Care Act has also resulted in cost savings for both consumers and taxpayers. The law requires health insurers to provide consumers with rebates if they spend too much of a consumer's premium on advertising and marketing instead of health benefits and quality care. Since this requirement has been put in place in 2011, almost $2.9 billion in total refunds have been paid to millions of consumers. And before the Affordable Care Act, insurance companies in many states were able to raise rates without explaining their actions. The law brought unprecedented transparency into health insurance pricing through the rate review process, and in 2015, rate review led to an estimated $1.5 billion in savings for consumers. Since the Affordable Care Act became law, healthcare prices have risen at the lowest level in 50 years. The Congressional Budget Office has estimated that the law will generate substantial deficit savings that grow over time, translating to a total savings of more than $3 trillion over the next 2 decades. One critical provision of the Affordable Care Act is the creation of the health insurance marketplace. The marketplace was designed to foster competition, facilitate comparison shopping, and ensure affordability. 3 years in, the health insurance marketplace is a competitive, growing, and dynamic platform, a transparent marketplace where issuers compete on price and quality, and people across the country are finding health plans that meet their needs as well as their budgets. Every year, we encourage consumers to return to the marketplace and shop for the plan that is best for them and their family. For 2016 marketplace coverage, approximately 67% of marketplace consumers selected a new plan and saved an average of $42 a month or $500 a year in premium costs. In addition to providing consumers with a simple way to compare and find the plan that's right for them, the Affordable Care Act also includes tax credits to help make that coverage more affordable. Roughly 85% of marketplace consumers receive these tax credits, and for 2016 coverage, their average monthly premium increased by only 4%, or just $4. After taking these tax credits into account, nearly 70% of healthcare.gov consumers had a coverage option for $75 a month or less, and 74% had an option for $100 a month or less. And importantly, consumers say they can now afford primary care, prescription drugs they could not afford before the Affordable Care Act, and a majority are satisfied with their coverage. While we are encouraged by the progress we have made, we know that implementation of the Affordable Care Act is a multi-year process. At CMS, our efforts to improve all of our programs, including the marketplace, are an ongoing commitment. This year, among numerous other efforts, we are taking steps to enhance our outreach to young adults who are more likely to remain uninsured. We have also strengthened requirements for enrollment through special enrollment periods, ensuring that this tool is available for consumers when they need it while preventing misuse and abuse. And we aren't the only ones that are learning. Since the Affordable Care Act became law, I've seen an unprecedented amount of innovation in the private sector. The marketplace is increasingly serving as a laboratory for strategies that are helping improve care and control costs. For example, one issuer is creating plans based on the different needs of unique geographic communities, bringing together interdisciplinary teams focused on improving care for high-risk populations in particular communities. We look forward to continuing to work with Congress and other key stakeholders on ways to strengthen our operations to ensure the American people have access to affordable coverage and high-quality health services. Using the tools created by the Affordable Care Act, we are all working toward a healthcare delivery system that works better for everyone, where care is improved through better coordination and integration, where we spend our healthcare dollars in smarter ways, and where our system is person-centered and Americans are healthier. I know you have a number of questions, and I'm happy to answer them to the best of my ability.
Thank you, Mr. Kunahan. Ms. Blumberg, you're now recognized.
Mr. Chairman, Ranking Member Cartwright, and members of the committee, thank you for the opportunity to testify before you today. The views that I express are my own and should not be attributed to the Urban Institute, its funders, or its trustees. The Affordable Care Act can claim substantial successes, including health insurance coverage for 20 million additional people through Medicaid and private non-group health insurance, and the elimination of discrimination related to health status in small employer and non-group markets. The law also has contributed to the slowdown in national health expenditure growth and has created significant price competition in many non-group health insurance markets. At the same time, employer coverage rates have remained steady and there have been no adverse employment effects. No one should expect one piece of legislation to address all problems in the nation's complex healthcare system, nor should one expect the full promise of the legislation to be met in the first few years of reform. Now is the appropriate time to assess remaining issues and to work seriously to improve upon these without sacrificing the many gains already achieved. I'm going to address 2 areas where public policies could make further strides toward ensuring access to adequate, affordable health care regardless of health status or income. First, some geographic areas have had less success engendering strong price competition in their non-group insurance markets. Second, while the ACA has improved affordability for many families, some still face high health care expenses relative to income, given premiums and out-of-pocket costs. In many larger states, the ACA has led to strong insurer participation in non-group insurance markets and true price competition for the first time, replacing the previously rampant insurer competition for the best health care risks. Our research shows that areas with low premiums and low premium growth tend to have more insurers competing, larger state populations, and competition from provider-sponsored and formerly Medicaid-only insurers. Nationally, 48% of the population lives in rating areas where the lowest cost silver premium in the marketplace either decreased or increased by less than 5% in 2016. However, 36% of the population lives in areas that experienced increases of 10% or more. Thus, the dynamics at play are uneven both across the country and across areas within individual states. We need to design approaches that improve competition where it is missing without disrupting competition where it has been successful. Competition could be strengthened by reducing insurer and/or provider market power, adverse selection into the non-group insurance market, and insurance policies not compliant with ACA standards. Strategies such as continuing the reinsurance program or introducing a Medicare-based qualified health plan can be useful to address these problems, but markets vary considerably, as will the appropriate types of intervention. The attraction of the ACA's private sector focus was its potential to create real economic competition, yet that approach also allows for instances of continued local variability. Next, healthcare affordability remains an issue for some. While the share of families reporting difficulty paying for medical bills or having unmet medical need due to cost has decreased significantly since 2013, not all families have enjoyed similar gains. Poor adults in 19 states are ineligible for Medicaid because their state governments did not choose to expand eligibility, despite the strong state budgetary advantages of doing so. Further incentives or other strategies may be required to bring all states into the expanded program. Financial assistance through marketplace tax credits and cost-sharing reductions are generous for those with incomes below 200% of the federal poverty level, but assistance decreases markedly above that level, leaving adequate coverage for some still out of financial reach. Healthcare costs have grown much less than originally anticipated when the ACA was implemented. Using just a portion of the system-wide savings that have resulted from that lower growth, we could improve upon the ACA subsidies to ameliorate the remaining affordability gaps and further reduce the number of uninsured Americans. In contrast, repealing the ACA would, by 2021, increase the number of uninsured people by 24 million, reduce private insurance coverage by over 9 million people, increase state government spending, and substantially reduce the amount of medical care delivered to low and modest income families. The House Republicans' plan combines repeal of the ACA with the introduction of policies that would substantially reduce assistance to low and middle income individuals and would undermine the ACA's many advances in improving access to care for people with health problems. The ACA's underlying framework increases the sharing of health care costs between the healthy and the sick. The House Republicans proposed strategies such as continuous coverage requirements, elimination of benefit standards, sale of insurance across state lines, and individual health pools would place much higher financial burdens on those with current or past health problems. And while such strategies can create savings for those who are healthy at a given time, they discount the facts that we tend to develop more health problems as we age, and that even a 20-something who appears perfectly healthy one day can wake up the next to find his luck has changed horribly. Focusing on how someone benefits financially by being insured in any given year is to misunderstand the inherent nature and purpose of insurance and seriously underestimates the value of continuous access to adequate, affordable coverage regardless of circumstances. With that, I'm happy to answer any questions you may have.
Thank you, Ms. Blumberg. Chair recognizes the gentleman from Tennessee, Dr. DeJarle.
Thank you, Mr. Chairman, and thank you, panel, for being here. Mr. Kunahan, let's start with the co-ops. How many co-ops were initially created under the Affordable Care Act?
Initially, we had granted 24. One never started, so in all practice, 23.
Okay, and how many are still active today?
7.
7, okay, and we had a hearing in February, and at the time, I think there were 11, so there's been 4 more that have failed since February?
Yeah.
Okay. About how many individuals have been impacted by the co-op closures?
So I'm going to have to get back to you on that.
I have 870,000, does that sound right?
I need to confirm that one.
Okay. If you and your family were going to buy insurance through one of the remaining co-ops, would you think that maybe you should be warned that 2/3 of these co-ops have closed in the past year or so?
Yeah, I do not, and I'll tell you why. The co-ops are like any other insurance company that are certified by a state division of insurance. They have to have the same actuarial standards, the same capital standards, they have to meet a solvency requirement, they have to meet a variety of certain circumstances. If the state certifies those issuers, if the state certifies that co-op, that feels to me that they should be on level playing field with any other issuer.
Okay, well, President Obama said if you like your plan, you can keep it, but apparently if you get a co-op, that's not necessarily the case. You got a 2 out of 3 chance that you're going to lose your insurance. So you're saying you would still recommend people and their families to go to the co-ops to obtain insurance?
I would say that if they are certified and licensed by the state, which they are, that they should be judged on the same basis as any other, and I think it'd be unfair not to.
The 2/3 that have failed, they weren't certified and licensed by the state?
As you know, sir, this is a challenging business. The co-ops are not the first issuers to have felt the challenge of that or to have closed.
Okay, well, you painted a pretty rosy picture of the successes of the healthcare law. Our chairman tended to disagree. Now, Mr. Cartwright said that we're enjoying a historically low uninsured rate. What is the historical low, and what year was that noted or documented?
Well, as of 2015, the uninsured rate is 9.1%. That was a drop from 16% before the Affordable Care Act.
And what's the historical low? Do we know? I'd asked this question before, dating back to 1950, and no one knew, and they were supposed to get back to me, but they never did.
Okay, I will need to do the same, sir.
Okay. So how many people are uninsured now in America? What percentage?
9.1%.
And is that taking into account that people who have lost their insurance because they couldn't afford premiums? Has there been any study? I guess I'd like to know where we got this data. The chairman mentioned that 11 million had insurance. You're saying 20 million.
Yeah.
What did President Obama say was uninsured when we needed this law?
Well, I think the difference there between what the chairman had quoted and what I had quoted was the difference is Medicaid expansion. So the 20 million that I quoted, for example, included marketplace enrollment plus expanded Medicaid enrollment.
So the average person has not really been helped then by the health care law that has to pay for it with the increased deductibles and increased premiums. We don't really have a study showing how many are just opting to pay the tax that the Supreme Court ruled was not a penalty but a tax. Do we have any studies indicating how many people have just opted out of the insurance and chosen to pay the tax?
Well, I think it's actually the opposite. I think what we're finding is that the average American has completely benefited from this law, and I'll tell you how. A is through the elimination of pre-existing conditions. B is through the elimination of lifetime caps. C is there are no gender premium differentials that there were. There's expanded coverage. It's more affordable than before. It's more
I get the
transparent
talking
in its
point. You're in a
pricing.
parallel universe with what I'm hearing. We hear different things back home, but I appreciate and respect your right to have an opinion. I just don't know that those can be backed on facts. Now, we had $1.6 billion in loan money that was given out. Dr. Mandy Cohen was here before, and she said that we're going to recoup this. I asked why didn't they just call them grants, because I don't think we have any real chance of getting them back. Now, she said that they were very much loans, and we expect to get these taxpayer dollars back from these failed co-ops.
Yeah.
And at the time, she had just started. Can you give us an update of how successful the recoupment efforts have been?
So we are in the Department of Justice is engaged in the recoupment efforts. I cannot speak for them with respect to their progress. Happy to have somebody from DOJ come.
So a half year
report.
later, we still have no update on how we're going to recoup the $1.6 billion to these failed co-ops. This is taxpayer money. They have a right to know.
As I said, the way these monies can be received, how they can be recovered, is typically when administrative expenses are paid and runout claims are fully satisfied. For most of these wind downs, that has not occurred yet. So it's really premature to be able to speculate.
Okay, so I'm just about out of time, but I guess, I tend to agree with the chairman. We've seen 24 turn to 23 to 11, now we have 7, and you're telling people they should still go use these co-ops with confidence that their family can get insurance and they're not going to lose it, and then you're also trying to tell them that we're going to recoup the money from all these failed businesses. I have an idea we'll probably be having this hearing again in a few months, and I anticipate, unfortunately, the chairman's predictions will come true, but we'll see where we're at. But I would like to get the data on the numbers where you're saying 20 million are now uninsured, and I'd like to see how many people have lost their insurance, because that's what I tend to hear back home, not the successes that the both of you have laid out for us today. I yield back.
Thank the gentleman, and now recognize Mr. Cartwright for 5 minutes.
Thank you, Mr. Chairman. In the 6 years since the ACA was enacted, as I mentioned, Republicans have held over 60 votes to repeal or undermine the law, but they still haven't proposed a viable legislative alternative. Now, the Speaker recently unveiled his, quote, "better way" plan for health care. The title of this plan is something of a misnomer because it is the wrong way, not a better way. The better way plan is short on specifics, but contains many ideas that really would be harmful to working Americans. And Dr. Blumberg, I'd like to ask you, are you familiar with Speaker Ryan's Better Way plan?
Yes, I did read the materials that they released.
And you commented on this in your testimony. Do you think it's a viable alternative to the ACA?
Well, I think it is not an alternative to the ACA in terms of an equivalent way to expand coverage and to reduce costs for individuals regardless of their health status, make that coverage adequately accessible.
One element of the Speaker's plan is to encourage the use of these health savings accounts combined with high deductible health plans. And according to the plan, this is supposed to help patients understand the true cost of care. Dr. Blumberg, isn't it true that this change could increase the out-of-pocket costs for middle-class Americans?
Well, it certainly increases out-of-pocket costs when individuals move into a health savings account combined with a high-deductible health plan. They are designed to be, at this point anyway, to be combined with a high-deductible plan. Individuals then have larger cost-sharing requirements, but they have certain tax advantages which tend to accrue most greatly to those who are high income. So they are the health savings account itself can act, if not used for health purposes, as an additional IRA, which is beneficial to the high income. The problem comes in for those individuals who don't get the tax advantages and don't have the extra money to put into the HSAs. They're certainly disadvantaged, and it tends to pull healthy people out of the insurance market where they would otherwise be sharing healthcare costs with those with health problems.
Okay, so it's the Better Way plan for higher income people, is it?
Well, a lot of components of the Better Way approach would be most advantageous to those with higher incomes and those very much in particular who are healthy at a given point in time.
Well, do you think the people who couldn't afford health insurance before the ACA was enacted really need help understanding the true cost of their medical care?
Well, for the lowest income population, those that are assisted through the Medicaid expansion under the Affordable Care Act and those who receive the most generous assistance under the marketplaces really are in situations where having higher out-of-pocket costs are going to very much reduce the amount of care that they receive. And contrary to popular belief, individuals are not very good at discriminating between care that is necessary and care that is unnecessary. So what happens is when you increase their out-of-pocket costs, particularly for the modest income, they use much less care, and a lot of it is necessary care.
The Speaker's plan would also irreparably harm Medicaid. First of all, it would prevent any more states from expanding Medicaid as provided by the ACA. It would also force states to choose between receiving Medicaid payments as a per capita allotment or a block grant. Now, Dr. Blumberg, what would these changes mean for people who rely on Medicaid for their health coverage?
Well, in both cases, regardless of what the states chose, the amount of federal dollars going to states for Medicaid population would be reduced over time. There would be both initial reductions because of changes in matching rates. There would also be, the intent is to lower the rate of growth in federal dollars going to the states. The biggest concern, while there's danger for sure with the per capita caps, the block grant, as I read it and the materials that were released, suggest that the only mandatory populations that would continue to be required that states provide Medicaid coverage for under the block grant approach would be the elderly and the disabled.
Okay, now the Speaker's plan will once again allow insurance companies to discriminate by charging higher premiums based on health status, sex, and age, and it would eliminate caps on out-of-pocket expenses. Mr. Kunahan, aren't these the types of abusive insurance practices that the ACA protects against?
Those are good examples of dramatic improvements that the Affordable Care Act brought upon.
Speaker's plan would also harm seniors by raising the Medicare eligibility age to age 67. Now, the Center on Budget and Policy Priorities said this about the Speaker's plan, and I quote, "Overall, the plan would represent an enormous step backward for our country, reversing historic progress in expanding health coverage under the Affordable Care Act." Dr. Blumberg, do you agree with that statement?
I do.
I don't know why anybody would want to go back to the bad old days before the ACA, and that's what, apparently, exactly what the Republicans are trying to do with this misguided plan. I yield back, Mr. Chairman.
I thank the gentleman. We now recognize the gentleman from Georgia, Mr. Heiss, for his question.
Thank you, Mr. Chairman. I respect my colleague, but I thought we were here today to discuss the Affordable Care Act and Obamacare, and I have anything to say about it other than the false belief that somehow it has ushered us into the good old days. I mean, this has been nothing but a disaster and continues to be a disaster. Premiums and deductibles are rising. I hear it every time I go home. People can't afford it. Insurers are reducing plan offerings. Co-ops, as we've already discussed, are imploding. We have administrative requirements that are ballooning to the tune of $273 billion in administrative expenses attributable to Obamacare, which amounts to hundreds and thousands of hours of paperwork to try to keep up with the requirements. Enrollment is skewed, going down. I mean, I don't see how in the world this has ushered us into the good old days. It is absolutely a disaster every way that I can possibly look at it. Mr. Kunahan, you mentioned today that because of the Affordable Care Act, that a lot of people have insurance because of Obamacare, but what you did not mention, in all honesty, is that these folks are older, they're sicker, they're more expensive to insure even than the administration ever anticipated. And as a result, we now have insurers who are rising the premiums because it's so expensive to insure these folks. Kaiser predicts that premium increases this year are going to be steeper than they've seen so far, and it's already just gone up and up and up since the beginning. The former CMS administrator recently predicted the same thing. We have high deductibles that, quite frankly, are just making insurance coverage less affordable and less accessible to the people. This is anything but an Affordable Care Act. People can't afford it. I hear it constantly, not only from people in my district, but from small rural hospitals. Most 17% of the people have a deductible over $5,000. They can't afford the deductible. They go to the hospitals, and hospitals end up never getting paid, and they're going under. We've already mentioned Obamacare promised to keep the doctors, keep your health plan, and we, of course, all know that that simply has not been the case. Insurers have limited their provider networks trying to cover the cost of this thing. Brian Webb of the National Association of Insurance Commissioners recently said that the individual market is a mess. I mean, how in the world can we look at this in any other possible honest way but to say this is a disaster? And I really, Mr. Chairman, I really don't have any questions. I'm just flabbergasted that we are still in any way trying to defend this and trying to continue to push it on the American people rather than face the reality. We have fewer plans, we have fewer doctors, we have reduced choice, and I guess my only question is this the legacy of Obamacare? I don't see any other way out of it. So, Mr. Chairman, I thank you for holding this hearing, and I yield back.
I thank the gentleman, and couldn't agree more with his sentiments on the disaster that this legislation has turned out to be. Mr. Kunahan, is the co-op program in Obamacare a complete failure?
No, not in my view, and I'll tell you why.
Well, okay, tell me why, or
okay.
define to me what would be a complete failure if
Okay.
the facts, well, let me just recite the facts again. 23 programs were given money just 2 years ago, and 16 of them have already failed.
Yeah.
The 7 that haven't failed yet 4 are on corrective action plans. Isn't that accurate?
No, 6 are on corrective action plans.
So of the 6 that haven't failed, 6 of them are on 7 that haven't failed, 6 of them are on corrective action plans?
Correct.
Oh, wow, so it's worse than I thought. Because of the last 4 that failed, all of those were on corrective action plans, and they all failed here,
Yeah.
one in Ohio just a few months ago. So 23 started, 16 have failed. Of the remaining 7, 6 are on corrective action plans. Every other program that was put on, every other co-op that was put on a corrective action plan did in fact actually then later fail.
Yeah.
$2.4 million allocated, 1.5 or 2.4 billion allocated, 1.5 given out and now lost. So, and yet you don't think that defines a complete failure.
No, let me just, if I can, Mr. Chairman, just
So tell me what would be a complete
try
failure.
to explain why. So first of all,
Well, let me ask this way. If all 23 actually fail, would that be a complete failure? Because that's where this is headed.
well, I think we're seeing with the co-op program, as we are with other parts.
No, answer that question. If all 23 fail, will that be a complete failure?
I think if all 23 fail, it underscores how challenging the health insurance business is. I think it
But
underscores.
that's not what I asked you. Would it be a complete failure
I think
if
it
every single co-op that you guys authorized just 2 years ago failed? Would that be a complete failure? Because we all know that's where it's headed. 16 have already failed. The 7 left, 6 are on corrective action plans. They're going to fail too. So when all 23 fail, would that be a complete failure co-op program under Obamacare?
As I said, I think it underscores how tough this business is. I think it underscores how challenging it is to have it being a small business.
So, Mr. Kunahan, you're from
I
CMS.
have-
You're a witness here today, and I'm asking you to answer one question. If they all fail, if they all fall apart, like we know they're going to, is that a complete failure? Just give me a yes or no to that one. That's all I'm asking you.
I'm saying, Mr. Chairman, it underscores again that this is a very tough business.
Is it a
It's
no?
tough to be a new entrant
Is
in
it a
this
yes?
business. And, Mr. Chairman, I've worked for an insurance firm that was about the size of one of the larger co-ops. We became successful, but I understand very, very specifically.
Are you
what
saying
it's
some
like.
of these 16 are going to come back to life? They're not dead forever? They're going to miraculously revive and resurrect themselves? Is that what you're saying?
So what I'm trying to say is the following.
Or well, let me ask you this: Are you sitting here today and say you're going to assure me that the 7 left, that they're not going to fail? Those 7 are going to keep working. They're going to be fine. Are you
know,
telling me that?
Yeah. It would
No.
not-
Would you tell me that? Are they going to continue to be in operation? The 7 that haven't failed yet, are they going to still be good when you come back here in a few months and we have the same kind of hearing?
Nobody could make that kind of prediction, sir. But let me tell you one of the reasons why. It's because there are so many variables that can impact the success of a business like that. Most fundamentally, claim costs. So, for example, if an issuer like a co-op has a very tough year,
But we just
tough
heard
month
from
round-
you, Dr. Blumberg, and the ranking member that Obamacare is the greatest thing since sliced bread. We just heard that, and yet we have this phenomena in front of us. 16 of 23 have completely failed, and we know the other 7 are going to fail. And yet you just all told us Obamacare is the greatest thing in the world. So I'm just asking you, can we at least just focus on the co-op and say if all 23 of those fail, that part of Obamacare, at least that has to be a complete failure, right?
Yeah. So, as I said, I've worked for a company that's one of the sizes of the larger co-ops. What can impact the business of a co-op?
I'm not looking
is-
for excuses. I'm just looking for an answer to that question. If they all fail, is it a complete failure?
Yeah. What I'm trying to tell you, number one, is that the co-op program is not the whole Affordable Care Act. Number two is that it's a very, very tough, low-margin business. Number three is it deals with a lot of
You know what the co-op
variables.
program is, Mr. Kunahan? It's one more thing that was promised when Obamacare was first enacted that was going to be just so special. Just like you all just had said earlier that, well, one of the other things that was promised, Obamacare passes, there will be no one without insurance. We know that's not the case because you even said it. There's still several million people who don't have insurance.
Yeah.
One of the things we were promised when Obamacare passed is 20 million people will use the exchange. We know that's not true because you all had to change the definition. You now say, well, it is 20 million, but it's the exchange plus Medicaid expansion. Totally change the definition to meet that number. So not to mention all the other, if you like your plan, keep it, like your doctor, keep it, premiums are going to go down, all those other things that turned out to be false as well. And all I'm asking you is one program, the co-op program, and you won't answer my, it seems by definition, if 23 out of 23 fail, then you should be able to say then that, of course, by definition is a complete failure.
Yeah. So let me tell you, sir, what the co-op program has done. The co-op program has provided more choice. It's provided more competition. It's helped consumers in a variety of different states, giving them opportunities that they may have not had before. And let me tell you, if I may, sir, tell you something else. It's also given the opportunity to innovate. Several of these co-ops have introduced new types of care management programs that have been new in their markets and new in their states. That
Oh, so new and
others
so
are-
great, so new and so, that is laughable. So new and so great that they actually went out of business. Now, I find that to be laughable on its face.
But that others, sir, are replicating. So the health insurance business and the healthcare business, as you very well know, is highly dynamic. It changes. There are a lot of variables to it. If the co-op program has provided a lot of choice to people, and that's a key part of what it was for.
You willing to tell this committee today, Mr. Kunahan, that when you come back later this fall, and we have another hearing on the co-ops, that the 7 that are still in business are still going to be in business then?
Sir, I would, number one, be very happy to come
Couple-
back at any time. Number two is I could not predict the future of any issuer.
Because you were here a couple months ago and it was 11, and we asked you then, and you wouldn't commit anything. We said we think they're all going to fail. Here we are a couple months later, and 4 more are gone, and the other 6 of the other 7 are on corrective action plans. Let me ask you this: have you done anything to recover the $1.5 billion that's out the door?
Yes, sir.
What have you done?
So the Department of Justice is in the process of working with several of the
No,
co-ops.
I didn't say that. I said you, not you're CMS. You don't work for the DOJ, do you?
No.
Okay, so I'm asking CMS. You have the ability to terminate the loan agreements, don't you?
Well, what I was trying to do was...
Wait. Is DOJ a signatory on the loan?
What I was trying to say, sir, is that these are federal loans. Once those federal loans become in recovery, that moves over to the DOJ.
What are you? But I'm asking, what are you doing? You're the one who gave out you're the one who decided who got the money. You allocated the money. You gave it out. What are CMS doing to recover the $1.5 billion of taxpayer money?
The process of how this works, sir, is that when a federal loan goes into recovery of that sort, it moves to DOJ for that process. And I am very happy to have someone from DOJ come here to give you an update.
You can't terminate yourself.
Well, I'm talking about loan recovery. I thought your question was about recovery of the loan. The process for recovering a federal loan is that DOJ takes over that process.
But what have you done? Have you terminated the loan so that DOJ in fact can do that?
Sir, it very much depends on the situation of the co-ops. I think what's important for everyone to remember.
No, we know the situation, Mr. Kunahan. 16 of them completely failed.
And
what are you doing to get the money back?
And these are independent, licensed issuers by states. They compete just like any other health insurance company in that state.
Okay, I went a couple minutes over. I apologize. So we will now turn to the right fine gentleman from North Carolina, Mr. Meadows, for his questioning.
Thank you, Mr. Chairman. Good to see you both. Kevin, good to see you.
See you.
Let me do a little housekeeping, if I could, on one particular issue, Mr. Kunahan. You are aware, I guess, that Ways and Means and Energy and Commerce has issued subpoenas as it relates to, I guess, the cost-sharing reduction program. Is that correct?
Yes.
And so have you been instructed to collect materials that are responsive to that subpoena?
No.
You haven't?
No.
So no one has reached out to you? Because that's a real problem. If,
my job, Congressman.
no, I'm not, again, I mean, if that's your sworn testimony, so what you're saying is no one has asked you to collect any documents responsive to a congressional subpoena regarding that program?
Yeah, we have a staff of people that I work with that are responsible for collecting documents of that sort. And they're responsible for doing it. That's not in my role.
But you haven't been instructed. So have you instructed anyone to collect those documents?
No.
So are you aware of anyone who has been instructed to collect those documents?
As I said, sir, we have a whole staff of people that are responsive to that.
You've got a huge staff.
Yeah.
But you know the point I'm trying to get to.
Yeah.
Is somebody collecting the documents or not, Kevin?
Yeah. And Congressman, to that very issue that you're speaking to, we have tried to be as responsive as we possibly can because I know the issue about document retrieval is very important to the committee and to.
So when will we get them, or when will they get them?
And so I'll need to get back to you on that. I don't know that
But you're
type of
saying
date.
no one's asked you, and you've instructed no one. Wouldn't you know that if someone were instructed?
Sir,
Because you're the head of the agency. We've had a number of conversations
That's right.
about responses and
That's
the
right.
lack thereof.
That's right.
And I guess my question is, you've got a staff behind you.
Yep.
Are they aware of anybody collecting the documents?
Sir, I want to be responsive to you. Let me get back to you, please.
And you can get back to me by when?
I'll have to circle that back with you.
Well, I mean, it's not a hard question.
Well,
You got a subpoena. I'm sure when the subpoena came in, somebody said, oh my gosh, we got a subpoena, because we don't issue subpoenas just willy-nilly.
Right.
We only issue subpoenas after you don't respond.
yeah. And Congressman.
So have you been asked for the documents
And Congressman,
personally?
and
For-
Cong- and
not-
Cong- Congressman, we want to be responsive. I know we've already provided
Let
thousands
me
of
tell you,
pages
the
of
last
documents
person
to
who
you.
told me that, the last person who told me
Yeah.
that was not responsive, Kevin.
Okay.
I'm just telling you. And I apologize. I shouldn't be calling you Kevin, Mr. Kunahan. The last person who told me that was actually part of a rulemaking process, who they had been working on it for a year, and we came to find out they hadn't been working on it.
Okay.
And so I guess my question is, when can Ways and Means and when can Energy and Commerce expect a production of the documents according to the subpoena that you acknowledge you're aware of?
And sir, what I would like to say is that I need to get back to you with that timing.
Okay, so you can have, actually, it would be appropriate for you to get back to this committee, but also to Chairman Brady and Chairman Upton with regards to a time frame. And so can we expect a response by the close of business on Friday in terms of a time frame?
We'll get
Is
back
that-
to you. We'll get back to you.
Yes or no? Is that not reasonable?
Sir, I need to get back to you.
Mr. Kunahan, you do not have the option of not giving me a time frame, because in doing that, you're thereby forcing the same issue, and it would be a contempt of Congress to continue to stonewall. So is that what you're saying, is that you're not willing to give me any kind of a time frame?
Sir, what I'm telling you is the following. Want to be as responsive to you as possible, want to give you an accurate time frame. What I'm asking from you is to give me the time to be able to be responsive to
So
you.
what's a reasonable amount of time?
So as I said, sir, I need to go back with my folks, understand that,
Okay.
and
All right, so
get
let me-
back to you then.
Let me, by Friday, the close of business, I either want a response on why you can't respond by then, why you haven't been able to find it, or some kind of legitimate response in terms of a time frame. Okay?
That's fair.
And so as we start to see this, let me, and I apologize, Mr. Chairman, if you'll indulge me just a few moments. Let me say one of my concerns, and you know, philosophically, we probably have a big difference. I don't want to get into the philosophical differences. Let me tell you where I am troubled, is for all the stories of people who now have coverage, I continue to get a disproportionate number of people who are saying their premiums are going up or their companies are going out of business. And so today we're talking about really a co-op program. And I've had some of the major insurers in the country come to me saying that not only are they losing money, but they're hemorrhaging a loss of money because they can't get either this on a profitable point of view or costs continue to go up. Are you hearing some of the same concerns from insurance companies?
You know, let me tell you what I'm hearing. And I talk to a lot of CEOs. And in this past open enrollment, I was in 13 states talking to people, is that what I'm hearing is that looking at the traditional way of managing care, contracting with providers, servicing this new population is less effective than it is by designing newer, more customized approaches that often exist within Medicaid plans. So issuers.
Let me make sure I'm understanding that.
Yeah.
So in your 13-state tour and talking to CEOs, they're suggesting that we go to a Medicaid?
No.
Because I thought that's what you're saying
Yeah,
is.
I apologize, I was not clear. What I meant to say was that if you look at issuers that have had a strong Medicaid background, that have served the Medicaid population, that work to design and customize care management tools that are more specific to this new type of population, they're finding themselves being more effective than those that have just traditionally served, say, the small group insurance market or the large group market.
But you and I both know that I'm a numbers guy.
Yes.
In a Medicaid patient, the amount of money spent per Medicaid patient is higher than the other patients typically. I know it is in North Carolina, exponentially higher.
Yeah.
So
Yeah.
what you're saying is that we need to go to a model where we spend more per patient?
No, I'm actually saying the opposite. What I'm really saying is that one of the interesting things I'm seeing in talking to CEOs is that they are retooling their care management models. They're retooling their provider contracting to match a number of issuers that have been successful in this business from the beginning. And what we're finding, Congressman, is that there's a clear opportunity for issuers that have thought of this market more strategically, that have used a lot of data to understand the specifics of their market, understand the uninsured in their state, design products that meet them, tier networks if appropriate, and provide new cost management tools.
Yeah, but
That's what I'm
So
saying.
let me go to one of the biggest one, Blue Cross Blue Shield.
Yeah.
In my state, obviously the largest provider. They have gone up 30%, 34%, and anticipated 20+% this year in terms of the insurance rates. We're hoping that it's lower. I talked to them just 2 weeks ago. So when you look at that, you aggregate all of that together.
Yeah.
That is not affordable health care.
Yeah.
And certainly my rates are not anywhere close to what they used to be 3 years ago. And so fortunately, I can afford to pay it. Many cannot. I mean, they're just barely scraping by.
Yeah.
What they shared with me is that emergency room visits are not really down. Is that correct? Because that was the whole premise. We would get this group of uninsured from going to use the emergency room as their primary health care provider. And actually, they're saying that went up and it continues to stay at an elevated rate. Are you finding that?
Yeah. So a couple things that you've raised. First of all, is that if you look at cost increases are at the lowest level during the ACA than they've been historically over the past 50 years. So that's
Lowest level
so
of
that's
what?
one.
Okay,
So
what are we comparing to?
So I'm just,
Mr. Kunahan,
Yeah.
how can you say lowest level? I mean, I'm 57 years old. I've been paying insurance premiums for over 35 years.
Yeah.
So 35%, 30%, and
Yeah.
18 to 20% is not the lowest level of increases that I've faced. That is just factually incorrect.
but if you've looked at the average in the markets, so for example, if you looked at the cost increases on average.
Let's look at just North
nationally-
Carolina. You know I was going to be here, and you know my numbers, and so let's look at North Carolina. Is it better in North Carolina over the last 3 years than it was in the previous 10 years in
Well-
terms of rate of increase?
Yeah, and unfortunately, Congressman, I don't have the benefit of the insight of North Carolina per se.
Well, you can
But what
report back to me on
But I can speak to nationally, and I can tell you from 2000 to 2010, the average rate increase was 8%. From 2010 to 2015, it was lowered to 5%. So look, do we?
But
So I'm
Mr.
talking
Kunahan,
nationally.
So what you're saying is we're an anomaly in North Carolina? But is that your sworn testimony?
What-
That because we went 30, 35, 34%, now 18, and we are astronomically more than anybody else?
But, sir, what I am saying is that there's not any monolithic or consistent level of rate increases nationally. If you look at rate actions, they vary by urban area versus rural, as you and I have discussed in the past.
They vary by Medicaid and Medicare more so than anything else, and I'll yield back.
Well, okay, all right.
I thank the gentleman. Now recognize the gentleman from Tennessee for additional round of questions. Well, after you, we'll go back to the Democrat side.
I guess I'm going to kind of follow up where Representative Meadows was on numbers. You were saying that 20 million people now have insurance. What percentage of that is Medicaid expansion?
Roughly half, about 9 million.
Okay, so what did President Obama claim we had in terms of the number of uninsured when he was proposing his health care law?
No. I can't remember, Congressman, exactly what he
We
quoted
want to
there.
use your percentage. You said 16%.
Yeah, oh, excuse me, the percentage of uninsured.
Right.
Excuse me, 16%, yes.
Okay, and we have 300 and some odd million people in the country, so 40, 45 million people.
Yeah, 43 or so, yeah.
Okay, so what we've done then, we've doubled the number of people on Medicaid, and of the other 10 million that now have insurance, how many of those have significant subsidies?
About 85% of our population have subsidies apply.
Okay, I can see
Tax
where-
credits
I
apply.
can see where the cash flow problem might be coming from then, because only just $1.5 million then are actually paying for their health care. Or small number, small percent.
Well, I guess I believe, Congressman, that everybody's paying for their health care. It's just that these individuals, based on their income, are getting tax credits that help them make it more affordable, but everyone's paying.
Did we ever figure out how many people, there are people who are living here illegally that are getting health care, correct?
So I'm not familiar about the number of people illegals that are getting health care
Okay.
in this country.
Seems like there was an estimate of, I don't remember, 10, 15 million people possibly that were getting that. You don't know. We're talking about the cost of deductibles. I think even President Obama acknowledged that too many Americans are straining to pay their physicians for their deductibles and cost. And I think somewhere that you'd said the deductibles had decreased $850. We've heard numbers thrown around in here, upward to $5,000 is the deductible cost. Yeah. Why the discrepancy? I mean, that's a big difference.
Well, the median deductible in our plans actually was lower this year by about 5% from the year before to about $850.
That's the median, and that's for
Yeah.
the people who are being subsidized, the 10 million who are not getting Medicaid expansion.
Yeah, that's correct. That's in that number of the 11 million. That's right.
Okay, so basically healthcare costs have gone up for about 90%, maybe even 95% of Americans because of Obamacare.
I think it's actually the opposite, sir.
You're saying that healthcare costs have gone down?
What I'm saying is that healthcare costs have been made more affordable than ever because of the Affordable Care Act.
Well,
If you look at last year, just as an example, the average individual out-of-pocket increase went up by $4, 4%. So we're making costs more affordable. We're making coverage more accessible.
And the co-ops are going broke, and there's been money that's come out. The court ruled that the Obama administration was using funds to subsidize insurance companies that wasn't authorized to do. That's probably a topic for another hearing. Ms. Blumberg, you're talking about access to care. I practiced medicine for 20 years. I know if you're on Medicaid, you essentially have no deductible. You can go to the ER, you can go to a clinic, but if you have private insurance, if you go to the ER, your deductible might be $300, $400 or more. So even if you're have an emergency, you can't afford to go to the ER, so you might wait to the next day to come see the doctor. I know I've seen that happen. Now people have deductibles up to $5,000. Middle-class folks are not going to the doctor, and they're not seeking to get care, so their quality of care is actually going down. We have helped some people. I mean, we have helped some people, as you said, we've helped people get Medicaid, and we've helped subsidize people, but there's a whole lot of other people hurting because they can't afford to go to the doctor, or they won't go to the doctor, and they let problems fester because of that high deductible. What would you say to them?
Well, I think with regard to the emergency room care, according to the rules under the Affordable Care Act, if it's emergent care that you're receiving through the emergency room, you don't face those deductibles. So it may be, yes, if you're going in to get non-emergent care through the emergency room and you've got a private insurance
Are you talking
plan,
Medicaid or private insurance?
both. So, but if you're getting non-emergent care, then the out-of-pocket cost is going to be significant if you go use the emergency room, because the intent is to give financial incentives to get alternative sources of care for non-emergent care. And what we have found in our survey work is that indeed the percentage of adults reporting a usual source of care outside the emergency room has increased significantly since 2013, and those not obtaining necessary care due to cost has gone down substantially since then.
I'd like to see those numbers. Mr. Kunahan, quickly. How many people now, Obamacare has been around for a while, how many people have paid the penalty on their IRS taxes rather than getting health care? In other words, how many people had health care that have dropped their health care and opted to pay the taxes?
Yeah. So sir, I can't remember the exact number of people that have paid that penalty. I'm, again, happy to
Can
get
you
back to that
ballpark it?
figure.
Can you guess?
I would really.
Okay,
need
we
to
still
get
have
back.
10% uninsured by your number.
9%,
So we,
yeah.
9%, okay. So that's roughly 30 million people. Who are they?
Excuse me.
Who are the 30 million people that don't have insurance? If 10% are still uninsured and we have all these other people that now have insurance,
yeah.
who are the ones that don't have it?
Yeah, so it's a couple different segments. So one would be Medicaid expansion states that haven't expanded Medicaid, significant component there. Number two would be young people. I'd mentioned earlier about the importance of enrolling younger folks and the outreach efforts that we're making to that. That's another cohort that's critical for that.
Yeah, it's really expensive for young people. I know that by talking to them. But I think what we've done is shifted health care. Some people that didn't have health care, or now they get subsidized, but a large group of people who had health care can't afford it now. So they're paying taxes to the IRS and going without insurance. And the ones that do have high deductibles, and they can't get health care because they're afraid to have to spend their deductible. But somehow you both seem to think this is a success. Not at all what we're hearing back home.
Yeah. To your point, sir, around young people and affordability, the vast bulk of them would be eligible for subsidies, the tax credits, and think that would make that coverage much more affordable for them.
But that's going to make the overall program. Anytime you give cash subsidies to somebody, it makes it way more expensive somewhere else, right?
Yeah, as I said, sir, our job is to enroll people into affordable care. I think we've made good progress. We've got more to do, as you say.
Sounds like socialized medicine. Thank you.
I think the gentleman would now recognize the gentleman from Pennsylvania.
Thank you, Mr. Chairman. So I'm going to throw this one open to both witnesses. It's a toss-up question. Mr. Heiss of Georgia just said because of the ACA, we have fewer doctors. Is there any substance to that? Do we have fewer doctors in this country since the enactment of the ACA?
I don't know that we have any evidence of that whatsoever.
That would have been a shock to me. And of course, my friend Mr. Meadows of North Carolina was lamenting the premium increases, and he was talking about his advanced age, and I'm a bit long in the tooth myself. And I was a business owner for many years, and year after year, we would have premium increases. This is long before the Affordable Care Act. 20% and 30% and 35% in a single year, and that was tough to take. It's still tough to take, but how about either of you? Can you put your finger on the ACA as the reason for annual premium increases, as opposed to what went on in the world before ACA?
Yeah. If I could just answer that, Congressman, I understand exactly what you're referring to. And I actually think that the ACA has had the exact opposite effect. It's moderating increases. And I'll just give you an example. In the mid-'80s, mid to late '80s, annual trend, inflationary trend in health insurance was in the mid-20s, 24, 25, 26%. That's beyond the impact of any utilization expense. That was pure inflationary trend. That's been dramatically cut back. So I think that helps prove your point.
Do you want to weigh in on that, Dr. Blumberg?
Sure. Yeah, there definitely has been a long history of variability in premiums from year to year. What we're finding in terms of the increases in the non-group marketplace plans, which I think is the focus of some of the concern here, is that there is huge variation by geographic area. We have seen that in the areas that tend to have the biggest increases, we're talking about the smallest population centers. We're also talking about seeing larger increases coming where the premiums had been in the prior years quite low relative to the national average. And so we think some of this is a regression to the mean over time, that some of these insurers came in too low and they're correcting now, but it's not necessarily that they're all going very high relative to what you're seeing in other parts of the country, but they made some errors in judgment originally, and they're correcting for them. So some of these large percentage increases are on much smaller premium bases, and so the
like a market correction.
Exactly.
All right, and I don't mean to cut you off. You have long, interesting answers, but we're on a clock here,
Sorry.
so we have to have short, couple sentence
Understood.
answers, not paragraph answers. Your research found, I quote, rates of increase vary tremendously across states and across rating areas within states. Question is, why do premium rates vary in this way?
They vary depending upon the market conditions that were there prior to the Affordable Care Act to some extent, how many insurers are competing, and that is related to the historical situation, what types of insurers are competing, and the types of insurers that have come in or have exited from the market.
Okay, and here's my question. The Affordable Care Act, has it helped facilitate increased competition that is needed to drive down the rates?
Definitely, because in the non-group insurance market in particular, prior to the ACA, we didn't really have price competition in these areas. That what the insurers were doing was competing for healthcare risks. Now there's transparency, there's equivalency of the plans, and so for the first time, we're seeing price competition where we didn't see it before in this market.
Now, Mr.
Congressman,
Kunahan,
is
I
there-
want to get your answer on that as well.
I just wanted to say, in addition to that, we have significantly enhanced the quality of the coverage that the individual market now gets access to, both the substance of that coverage and also the elimination of the ability to discriminate in that coverage. So just the elimination of pre-existing conditions alone is a significant and huge improvement. The fact, again, that there's no annual lifetime maximums, there's no caps on specific types of procedures. All these types of things are significantly enhancing.
No penalty for being a woman.
That is exactly right. In my old state, women were typically priced twice as high as men for the same type of coverage. We've also seen that the number of bankruptcies due to medical costs have dramatically reduced since the introduction of the ACA. So again, significant movement and progress.
Now, it's also important to remember that the premium rates insurers have filed for next year, 2017, are not necessarily the rates that will be approved by state departments of insurance. Am I correct in that?
Correct.
All right. In fact, ACA created a rate review program to help state departments of insurance strengthen their rate review processes, right?
That's correct.
According to 2015 HHS report, rate review reduced total premiums in individual and small group markets by $1.5 billion.
That's right.
Rate review process. Mr. Kunahan, what other tools did the ACA provide to help consumers mitigate the effects of the premium increases?
Well, number one, we talked about the tax credits. We talked about other ways to make things affordable. You've mentioned already the ability of states to take a more aggressive, transparent view for the creation of rates. We've created more competition. We've created more choice. Just to give you a quick example, last year, the average enrollee had an option of looking at 3 health plans, 3 issuers, and 50 health plans to choose from. So there's a variety of different ways that we're using the marketplace to help dampen prices and give people more options.
You know, I was just complaining about, as a business owner, what it was like to go through these every year, double-digit premium increases. I just saw a figure that premiums increased by 58% during the last 6 years of the Bush administration. Have you seen that number?
I hadn't.
My colleagues in the majority have also brought up the fact that United Health and a small number of other issuers have decided not to participate in the ACA marketplaces in 2017 as evidence that the ACA is not working. Dr. Blumberg, what do you make of that argument?
We look pretty seriously at the United situation, and they came in mostly in the second year. They really didn't participate much at all the first year, and where they came in, they ended up coming in really high. And in a few areas, they were the low-cost insurer, but in general, they priced very high relative to the others. As a consequence, it's a very price-sensitive population.
Is
They
that
really didn't
evidence
get
the
much
ACA is
enrollment.
not working?
No, it's evidence that the United strategically was not paying enough attention to how this market was working.
Okay.
And Congressman,
Yes.
that is not uncommon in business of any sort or in the health insurance business. People's strategies change. Their strategic direction can evolve. So we see more of that. But the
Not
current,
only that, startup businesses in general fail for a whole spectrum of reasons, right?
that's correct. And
right.
particularly, health insurance is a low margin, very, very challenging industry.
Now, a recent article in JAMA, the Journal of the American Medical Association, is titled "Reports of Obamacare's Demise Are Greatly Exaggerated," notes other large insurers like Anthem and Cigna have, quote, expressed more confidence in the ACA's marketplaces as a business opportunity. In fact, Cigna is even planning to expand its presence in the marketplaces. Mr. Kunahan, what do you make of the fact that some insurers are deciding not to participate in ACA marketplaces in 2017?
I think it's a couple of things. I think, A, this is an example that strategies evolve. 2, I think an example is that people look at opportunities. You used an example of Cigna. That's a good example. There are other examples of big national publicly traded firms that are expanding into new markets. I think the other thing that's showing is that with any new market, and this is a new market, and there hasn't been a new market like this in a long, long time, it takes a combination, whether looking at it from an underwriting perspective, an actuarial perspective, a risk management perspective, a care management perspective, a provider contracting perspective, all these are different. And what we're finding is that those that are using the same kind of pattern that they use for their commercial business are being less successful and are in the process of retooling versus those that have looked at this market and this enrollment more uniquely.
All right, last question, and this is the $64,000 question, Dr. Blumberg. If my Republican friends get their way and we repeal the ACA, what do you think will happen to health insurance premiums in this country?
Well, I think health insurance premiums would go up extraordinarily for those who have past health problems or current health problems. And that's really the key, is are we going to leave those who are most vulnerable at their time of most need with inadequate access to care, or are we going to pool them together and with people who are currently healthy?
Well, thank you. I yield back, Mr. Chairman.
I thank the gentleman. Dr. Blumberg, Mr. Kunahan wouldn't answer the question, probably can't answer the question. He's in the administration. When I asked him the fact that 16 of 23 co-ops have already failed and the other 7 are going to, he wouldn't answer the question whether that's a complete failure. But you don't work for the government, you work for the Urban Institute, is that right? And you're here on your own capacity today.
Correct.
All right, so you're not part of the administration, right?
I am not.
So when you have a program where 23 co-ops are created in this co-op program in Obamacare, 16 have already failed and 7 are going to, would you describe that as a complete failure?
I'd say it's you can't say that's a success when all of those plans fail, but I also think that the important thing is for us to look at why those plans failed. I think it was a combination of issues related to they had a big hill to climb as new insurers to begin with. But I also think that the problem with the redefinition of what the risk corridors were going to be and making those, forcing those to be budget neutral, which they were not intended to be, had bad implications for those co-ops as well, and that was something that came after the Affordable Care Act. I also think that it's an indication that we have some improvements to make in the risk adjustment system that I think are some in progress, additional ones that could be done, and I think that the timing of those support payments from the risk adjustment reinsurance and risk corridors were important there.
Mr. Kunahan, we've asked certain individuals to be scheduled for transcribed interviews, including yourself, Mr. Cleary, Ms. McNeil, and I guess just 3. When are we going to get those scheduled?
Sir, I need to get back to you on that. I don't do that type of scheduling, and happy to respond to you fast.
Yeah, but you're the boss here at CMS, and so we've been trying to do this. And can you make a commitment that you're going to get it done here? And we want to get it done this month.
You're absolutely right, sir, that I am the boss. But the co-op program, for example, has its own director, its own team of people that are dedicated to it. I need to circle back with you.
But they answer to you, right?
Correct.
Okay, well, that's why I'm asking you. You're the guy here on the witness stand. You're the boss of CMS, so we want to get you and 2 other people in for an interview.
Yep.
We're just asking you, can we make that happen in 2 weeks?
Yeah, and sir, want to comply with that? As I said, I'm just looking for
Okay,
the time to be able to get back to you.
We've also requested documents from you. When are you going to give those to us?
Sir, we have already given you, as you're probably very, very much aware, thousands of pages of documents to be responsive.
We want them all. We want the ones that we
And-
need, the ones we've asked for, not some, we hear this every time in congressional committees. We've given you thousands. I don't care if you've given us a bazillion. If they're not the ones that matter,
Yeah.
who cares? I want the ones that matter. When are you going to give those to us?
Well, and the ones that and I'm not sure how you're defining the ones that matter, but the ones that have
The ones
business
that matter
risk.
are the ones we asked for.
Well, the ones that have business risk to those businesses, those co-ops, have been available in camera. They continue to be available in camera to your staff. We're not hiding anything from you, but
It sounds like you are when you say in camera. Give them to us. We want them. We don't have to come over there with special thing in a special room, look at them, can't take notes and all this. We've been through this before in other committees as well. It's just ridiculous. Congressional investigation, congressional inquiry. We want the information. Give it to us.
yeah, and we want to give you the information, but we can't have the information leak out for businesses. As I told you, I worked for a small
Now
business.
that is again almost laughable. They're all going to fail. Anyone with a brain can see that. And now you're telling us, oh, we got to be, we're going to be confidential with the information, but to say you have to see them in camera because, oh, by the way, some of these things might fail, we already know that. Anyone with a brain knows it because every one of these are going to fail. So that's sort of a lame excuse, frankly, Mr. Kunahan. Just let us have the documents, will you?
Well, sir, I respectfully have a different perspective on your comment about them all going to fail. What I would tell you is that we have an obligation, a fiduciary obligation, to make sure that no confidential information about their businesses gets leaked out and can be used against them. And I'm sure you can appreciate that.
I certainly can, and we can certainly keep confidential information confidential.
Yeah.
How about the materials relating to the Co-op Risk Committee? When are we going to get those materials?
Yeah. So I will have to check on the status of your request for information related to that. That's not an area that I personally get engaged with, so I will follow up with you on
What
that.
about the notes from the weekly calls you have with the co-ops? When are we going to get that information?
Yeah. Sir, as I said, I'm not responsible for responding for those types of document requests, and will be happy to get back to you with details.
The gentlelady from New Mexico is recognized for 5 minutes.
Thank you, Mr. Chairman, and thanks to the witnesses. So I know that Mr. Kunahan is very familiar with New Mexico and our woes. And to be fair, given what I've heard in your answers today and in reading your prepared testimony, and I agree with my colleague, Mr. Cartwright, that there were plenty of significant difficult issues pre-ACA. The reality is that a private insurance, private healthcare market has significant challenges for a sick population in this country that's not very homogeneous, and we are effectively, as a result, have been very poor healthcare consumers. I believe in the fundamental consumer protections unequivocally in the ACA. But between my colleagues asking questions, I find myself in a very interesting position where I may disagree with you about the ACA and its impact and about whether or not we've really been proactive in dealing with the issues that we were clear, or we wouldn't have had a risk corridor, we wouldn't have worked on a co-op model. We knew there were going to be some very interesting competitive issues. We were also a bit nervous about premiums and premium stability, which is why we were alerted to the fact, but I think in many states, particularly mine, very surprised by the out-of-pocket costs and the very high deductibles, which quite frankly has just pushed people into emergency rooms, and we just cost shift somewhere else. And as you're well aware, New Mexico's never had competition in the marketplace. And now, in my district, this minute, I only have one. Now, Secretary Burwell, and I know that you're aware, have known that these issues, so to the credit of my colleagues behind me, you've seen them coming. I've alerted the White House. I've alerted HHS. I've alerted CMS on multiple occasions. Our superintendent of insurance is, feeling really confident that he can manage this. I would say I don't share his confidence. We got another 10,000 enrollees, 80% of whom need those and get those subsidies are going to find themselves maybe in a precarious position. The rates that are published that are not yet agreed to is an 80% increase by Blue Cross Blue Shield. That was with Presbyterian in. If they're out, I don't know what that means. And given that nationally they've been another one like United that's given us great pause about what they can and should and are willing to do. So given that New Mexico doesn't fit any of the things that you've described as successes, what are we going to do? And that co-op is in the most precarious position. What strategies have you specifically thought about, given that rural and frontier states and poor states, higher risks to begin with? It's not like we didn't know that.
Yeah.
I've seen nothing that's been targeted or strategic for those states. And I've seen very little, quite frankly, from the administration about dealing with these issues, except telling me that the marketplace is incredibly competitive and people have great choices, and it's all going to work itself out. So I want to know, and I haven't given you very much time, but what specifically have you done in the 7 years given these serious issues? And I know that you weren't there for the whole 7, but you are at the top now, about New Mexico, and what are you going to do to help us make sure that consumers really are, in fact, protected, as is the vision in the ACA, because I'm not seeing it.
Okay. First of all, thank you for the question. I happen to be fairly familiar with New Mexico and with the competitive environment there.
Or the lack thereof, you mean?
Aware too, I have a valued relationship with the DOI superintendent, and actually just spoke with him about 10 days ago about the competitive environment. Also rate actions by the Blue Cross. So I had that review. So we had a good...
Did he actually tell you that Presbyterian was going to pull out yesterday?
No, he did not.
I would say that your relationship with our superintendent needs to be reevaluated.
Well, I value the relationship that we have. And I would tell you that he and I have discussed a variety of things about different issuers. One thing that we both understood is some of the complexity about urban versus rural counties.
In fact, the rural counties, Mr. Kunahan, have higher competition given the regional plans that are on the marketplace. It's the urban area that is the most at risk currently today, with both the co-op and now all the large insurance carriers are pulling off the marketplace in the largest city and the most urban area in the state. It's contrary to what you just said, in fact.
Yeah. Well, one of the things we could talk about is I think that the co-op is a good example of new choice, of more competition, of innovation.
Right, but that hasn't translated, and I'm out of time. But the reality is, I'm going to ask you to give me in writing, and hope that the chairman will continue to let me have a few more seconds. I need those specific strategies, given that we have asked for them from this administration on multiple occasions. I believe you have an obligation to hold us accountable, to work on strategies that will protect those consumers, because so far that is not translated, and I think we can get it right. We have significant challenges. That is not occurring currently, and I don't think that the administration has really been thoughtful about that. In addition, which is not really in your wheelhouse, but I'd like you to take back to the administration, that I think that they should look very seriously at the 6% Medicaid cuts that are going to drive even more providers out of New Mexico. So you have a very precarious situation there that I'm not sure is getting the attention that it really deserves and needs. Thank you. I yield back.
Gentlelady yields. I now recognize myself for 5 minutes. Mr. Kunahan, to date, we know that 16 of 23 Obamacare co-ops have collapsed, and it's impacted 870,000 enrollees. That's including the Land of Lincoln co-op of Illinois, which announced just yesterday that it will close after only 3 years of operation, leaving 50,000 enrollees without insurance. What's more troubling than that, perhaps, is that CMS loaned nearly $1.5 billion to these failed co-ops, despite the administration's projection that the program would lose a significant amount of taxpayers' dollars. Over 40% predicted to never be repaid. That's a lot of taxpayer dollars. I think you would agree with that. A lot of taxpayers' dollars casually thrown away to prop up yet another failed facet of Obamacare. Mr. Kunahan, I'm concerned that despite the previous oversight hearings that we've had and on the failing co-ops and the staggering amount of taxpayer dollars that are at risk, that CMS still has yet to come up with a plan or a process for recouping the loans lost by these co-ops.
Yeah. So
am I right? I mean, tell me I'm wrong.
Yeah.
Do you have a plan to recoup the money?
we have a specific process for recoupment of monies. I explained some of it just before you were able to arrive, and if you don't mind, I'd like to explain
Very
it again.
briefly.
Yeah. So fundamentally, this is a matter of making sure that claim runouts are finally resolved and paid, and administrative expenses to vendors are paid. Monies left over from that are typically the best ways for us to recover money. The Department of Justice is in the process right now of doing just that with a couple of these co-ops.
So you're trying to do it through payment offsets or what?
No, I'm trying to do it with recovery of federal loans and recovery
Are you doing it with all of the co-ops that have failed?
as appropriate, at the appropriate time. But as I said,
when is the appropriate time?
Well,
I mean, after they failed, and there's no money left, right?
but no, not necessarily. And as I mentioned, the vast majority of these co-ops still are in runout, which means that their incurred but unreported claims still need to be paid.
Okay, so let's go back here. It's my understanding that now we've got 7 remaining co-ops. Is that correct?
Correct.
How are they doing? From my understanding, they're not doing well at all, that they're in very similar situations and that they're set to fail.
Sir, these are small businesses. They're small businesses in the health insurance business. This can very much depend on a month-by-month basis. So I would
Well,
tell
let
you-
me ask you something. You know, I was always taught that you don't want to throw good money after bad. Why they still got some money? Why don't we just go back and get it and recoup it and just call it a day? Obviously, if 16 out of 23 have failed, why should we think that the remaining 7 are going to make it?
the monies that we have been obligated already to those businesses. Those businesses right now are in the process of succeeding like any other business or any other insurance company does in the state where they do business. This is a tough industry, as you very well know. It's very tough to be a small business, and it's tough to be a small health insurance company. I used to work for one, so I can tell you that. But we're doing everything that we can to collaborate with the state divisions of insurance and with the co-ops to make them successful.
But it's not working. It's failed 16 out of 23. Another one failed yesterday. The remaining 7 are in bad shape, and you know it.
So, sir, if you look at the history of new entrants in health insurance, typically, at least half of them or so have a hard time making it. So this is not inconsistent.
Okay, well,
with the
let
industry.
me ask you something, Mr. Kunahan. Out of the 7 that are still currently operating, how many of them are profitable?
So profitability very much can depend on the
That's
month.
yes or no?
It depends on the month, sir.
Depends on the month.
Yes.
This month, how many of them are profitable?
I can't tell you that.
Last month.
The claims data that we have right now is typically.
Can you tell me last month?
Is typically through May. You know, we've got actuarially certified data through the second quarter. You know, we're trying, actually, we get that in August. We're trying to do our best to keep up, as we are with the state divisions of insurance. But when you're a small carrier like this, it very much depends on the claims you get for that month.
Mr. Kunahan, this looks like a total failure. I mean, not only are we throwing good money after bad, losing money, but now we got all these enrollees who don't have any insurance coverage.
Well, so can I give you another perspective on that? So
Please.
Another perspective on that is that because of these co-ops, we've been able to give people more choice. Because of the co-ops, we've been able to enhance competition in these states. Because of these co-ops, we've been able to innovate. Many of these new co-ops have come up with new care management models that are being replicated by some of their larger competitors. So there's been all sorts of
If I were one of their larger competitors, I wouldn't copy anything they've done. They failed.
But sir, there's a variety of different reasons that lead to the expenses in a health insurance company. Care management models are things that can help migrate between sizes of firms and profitability of firms. So I'm giving you 3 examples of where they've added specific value.
Okay. If there is a silver lining, perhaps you've just described it. I fail to believe that. Nevertheless, let's shift gears for 1 second, okay? Let's talk about, we know the co-ops are not the only entities that are struggling under Obamacare. United Health has pulled out of a number of markets, abandoned a number of exchanges due to profit concerns. If the nation's largest insurers can't assume the risk and burdens of Obamacare, why should we believe that anyone can?
Well, if I could just give you some examples for that, because
Please, very quickly.
Okay, I got a deep history in this industry. Often, insurers that came into this market were making some assumptions about the utilization and the morbidity of the new enrollees. What we're finding is some of those assumptions and old care management tools have been less appropriate to this new population than those that innovated and created new ones. And so many right now, issuers are retooling based on looking at new models.
Okay, all right, I need to finish up. I'm sorry, Mr. Kunahan. Out of all due respect, sir, they're failing, they're losing money, the patients aren't being covered, their premiums are going up. It looks to me like it's a total failure. I've got a closing statement I want to make. Okay. In a July 11, 2016 article on healthcare reform, President Obama acknowledged that too many Americans still strain to pay for their physician visits and prescriptions, cover their deductibles, or pay for their monthly insurance bills. That's directly from the president. Even the president can't avoid the fact that after 6 years, his signature healthcare reform bill has completely failed. Completely failed. Healthcare costs are higher than ever. Families have seen their premiums double and deductibles increase, and the average American cannot afford health insurance. This is why we've come out with Speaker Ryan's A Better Way policy agenda, and I hope that we will look at that. We all want health care coverage here in America. Republicans, Democrat, we want it. And we feel like we have a better way. Obviously, to anyone who's looking at this, this is not working. It is failing. Finally, there's some documents that we've asked you to produce. On November 20th, December 23rd, May 18th, We sent letters, and on February 17th, we sent a subpoena to Secretary Burwell. Are you familiar with this?
I am familiar with the requests, yes.
Have you been asked to collect any of the material?
Sir, a couple of things. One is, I know that we've already sent thousands of pages in response. Number two is, to the extent that there are requested documents that are confidential, that could put any of these businesses at risk. And again, I used
I
to
thought
work-
it was
I
a
used to
subpoena
work
we
for one.
sent.
We've made those available in camera. They remain that way, but we can't have those divulged publicly, or those businesses.
Mr.
are at
Kunahan,
risk.
if we agree on anything on this committee, Democrats, Republicans, Independents, or whoever, it is that y'all need to pay attention. And when we ask you something, we expect for you to get it to us. I don't think you'll find anyone who disagrees with that.
That's understood. But we have a fiduciary responsibility to these firms, as I'm sure you can appreciate.
I can appreciate that, but you have an even greater responsibility to this committee and to answering to the people who have been elected to represent the American citizens. All right, that's all.
Mr. Chairman, I have a unanimous consent request. The witness was questioned about profitability and was not able to answer questions on second quarter because they won't be out until, and audited until August. I request unanimous consent to put into the record financial press article noting that for the first quarter, at least 3 ACA-created co-ops turned Q1 profits in Maryland, New Mexico, and Massachusetts.
Without objection.
Thank you.
Mr. Kunahan, Ms. Blumberg, I want to thank both of you and thank you for taking time out to appear before us today. Is that it? Did you have anything else? We're all done. If there's no further business without objection, the subcommittee stands adjourned.